Yeah, so maybe I'll introduce Dr. Chetan, is one of the senior most GI surgeons. He's the chief of GI surgery at the prestigious KEM hospital, and he's going to talk on the relationship between IBD and cancer. Dr. Chetan, please.
So, good evening, everybody. Respected Kapoor sir, distinguished moderators, seniors, colleagues, and friends. The topic of my today's discussion is malignancy associated with IBD and FAP. So, as shown in this diagram, IBD can affect malignancies at all levels, beginning from skin, lung, it can cause cholangiocarcinoma, it can affect the small intestine, the colon and rectum, the anal canal, and also hematological malignancies. Besides this, the therapy related to IBD as well can lead to malignancy. So let us look into detail of how this occurs. So we all know that colorectal carcinoma is one of the most common malignancies associated with inflammatory bowel disease. Ulcerative colitis is a well-established risk factor for CRC. Its incidence is 4 to 10 times more as compared to the sporadic CRC which can occur. And the risk increases after 8 to 10 years of diagnosis or following diagnosis of high-grade dysplasia. So the risk at the end of 10 years is around 1%. It is 2% at the end of 20 years. And after 20 years, it is around 5%. In comparison, the association of colorectal carcinoma with Crohn's disease is not so well established and is a controversy. The common risk factors which have been implicated are the primary sclerosing cholangitis, where it is said that it increases the risk 3 times the normal, severe inflammatory activity, presence of post-inflammatory polyps, diagnosis made at a younger age, longer duration of IBD, extensive IBD with highest risk being in pancolitis, colonic strictures, left-sided colitis have intermediate risk, family history of first-degree relatives with colorectal carcinoma are more predisposed, and so are male gender. Now, as far as the pathogenesis of malignancy in IBD is concerned, it usually follows an inflammation dysplasia carcinoma sequence as compared to the adenoma carcinoma sequence which we see in sporadic colorectal carcinoma. Besides this, the molecular alteration in IBD also occurs in different order and frequency. In IBD, we see that P53 mutation occurs earlier and mutation in APC gatekeeper gene occurs later, just prior to carcinoma, in comparison to the other way around in sporadic malignancy. As far as the bacterial involvement leading to malignancy is concerned, there are 3 theories which have been put forward. The first is alpha bug hypothesis, which affirms that a single bacterium can lead to development of carcinogenesis. Second is the driver passenger hypothesis, where it states that after the first bacterium has been implicated and caused carcinogenesis, other opportunistic bacteria also add and contribute to further progress and development of malignancy. Whereas the common ground hypothesis states that there occurs increased permeability of the bowel following bacterial invasion of submucosal tissue, which leads to chronic inflammation and development of carcinoma. Now, how do you actually pick up this malignancy? So for this, patients should be under surveillance, and the recommendations as per the various guidelines are that patients with lower risk, that is colitis less than 50%, or patients with extensive colitis but minimal endoscopic or histological inflammation, they should be surveilled at every 5 years. Patients with intermediate risk, that is extensive colitis with mild to moderate endoscopic and or histological inflammation, and with patients with first degree of family member having malignancy but more than 50 years of age, they should be surveilled every 2 to 3 years. Whereas patients with peripheral sclerosing cholangitis, extensive colitis with severe endoscopic and histological inflammation, colorectal malignancy in first degree with less than 50 years, Patients with strictures in last 5 years and dysplasia in last 5 years should be surveilled annually. Now, what do you besides this, it is also said that an annual pouch surveillance should be done in patients who has undergone a ileopouch anal anastomosis, in whom the preoperative diagnosis of dysplasia or malignancy of the colon or rectum was there. Now, what do you actually see on this colonoscopy? So you will stratify the lesion depending upon the site, size, shape, surface, and surroundings. Now, it is important to do this because less than 2 centimeters, you can endoscopically resect it or do a EMR or ESD for larger lesion. Polypoidal lesion can again be treated differently if it is less than less than 2 centimeters or more than 2 centimeters. As far as the shape is concerned, as shown in the diagram, you get these different shapes, and each shape has a therapeutic implication of what you should be doing. Besides this, you also would want to know the degree or severity of dysplasia, whether the dysplasia is high-grade dysplasia, low-grade dysplasia, and unclassified atypical. Now, what do you do once you know that there is a dysplasia? So if there is a polypoid lesion or a non-polypoid lesion, which is less than 2 centimeters, without stigmata of invasive malignancy or fibrosis or distinctive border, then you could do an endoscopic block resection, that is either endoscopic mucosal resection, submucosal dissection, or a hybrid technique, and it should be undertaken by expert endoscopists. These patients are then post-procedurally followed up with close surveillance with either a chromoendoscopy or with targeted biopsy. Patients with high-grade dysplasia for first year should be surveilled every 3 months and subsequently annually. Patients with non-polypoid low-grade dysplasia should be surveilled every 6 months and then annually. Non-polypoidal lesion more than 2 centimeters without stigmata of invasive malignancy or fibrosis and distinctive border, again go an endoscopic resection, or you are justified in doing surgery as well if you are not comfortable doing it endoscopically. Again, like above, you have to surveil this patient periodically, every 3 to 6 months for first year and then annually with a colonoscopy. For an unresectable large lesion or with invasive carcinoma or an invasive dysplasia or random biopsy, again, you do surgery. You need to confirm before undertaking this the report by a second pathologist. Do a repeat surveillance colonoscopy should be done in invasible dysplasia and follow it up with annual surveillance. For indefinite dysplasia, again, you repeat the biopsy and confirm it by a second pathologist and keep them under surveillance with annual surveillance colonoscopy. With multifocal dysplasia, either low-grade dysplasia or high-grade dysplasia, surgery is the treatment of choice. And for sporadic adenoma, you could do an endoscopic en bloc resection. Now, here it is again, I want to emphasize that patients with unresectable non-polypoid dysplasia, they were higher risk of going into high-grade dysplasia or malignancy within 5 years, and hence, regardless of the grade of dysplasia, they should be subjected to colectomy, either a total colectomy, or in case of a low-grade dysplasia, you could do a partial colonic resection and keep them under surveillance. Now, what about primary prevention? Can you prevent malignancy occurring in patients of inflammatory bowel disease? Yes. So this primary prevention is independent of screening and surveillance strategy, which we discussed. The strategy is to control inflammation, and in this context, 5-amino-salicylic acid plays a great role in preventing colorectal malignancies occurring in patients with inflammatory bowel disease. What it does is it downregulates the cyclooxygenase 2. It inhibits the activation of transcription of nuclear factor Kb and phospholipase D. And it is believed that in doses more than 1.2 gram per day, it offers a significant protective effect in patients with ulcerative colitis. Now we come to small bowel malignancies. So small bowel malignancies is believed to cause 8-fold and 2-fold increased risk of small bowel adenocarcinoma in Crohn's disease and ulcerative colitis. So it is very clear that as far as small bowel is concerned, it is Crohn's disease which is the villain rather than ulcerative colitis. But however, the risk of neuroendocrine tumor is equal in both patients of ulcerative colitis and Crohn's disease. The risk factors in ulcerative colitis are extensive involvement and presence of peripheral sclerosing cholangitis, whereas in patients with Crohn's disease, it is the area which gets affected and the ileocecal region or the proximal colon which is usually involved. So the risk factors for development of small bowel adenocarcinoma are use of tobacco, male sex, early onset of Crohn's disease in childhood, long-standing small bowel inflammation, presence of penetrating or stricturing Crohn's disease, and patients with history of prior small bowel resection. Now, as far as the small bowel cancer in Crohn's disease is concerned, there is increased risk for developing both adenocarcinoma and NET, as we have discussed. It commonly affects the areas where there is inflammation, the distal jejunum and proximal ileum, and you should suspect the presence of malignancy in patients with refractory, long-standing stricturing disease or patients who present with relevant symptoms. And as far as surveillance is concerned, as of now, routine surveillance either with imaging or endoscopy is not recommended for small bowel cancers at present. Now coming to intestinal lymphoma. So intestinal lymphoma, it occurs around 2 to 3 times more in individuals with inflammatory bowel disease. It is seen more often in males, and it is predominantly B-cell non-Hodgkin lymphoma or lymphoma associated with Epstein-Barr virus, which occurs in them. It occurs in patients where there is ongoing intestinal inflammation for more than 8 years, and more so in patients who have been receiving treatment in form of thiopurines, a common immunosuppressant agent which is used. Now coming to anal carcinoma. Though the development of anal carcinoma in patients with Crohn's disease is not very high, but it is definitely higher than the general population. So incidence of anal squamous carcinoma is around 2.6 per 10,000 per patient year in patients with IBD with presence of anal or perianal lesions. So the risk factors are presence of humanopapillomavirus and patients with long-standing perianal and fistulizing diseases. Now coming to cholangiocarcinoma. Cholangiocarcinoma occurs 4 times more likely in patients with IBD. The lifetime risk in these patients of inflammatory bowel disease to develop cholangiocarcinoma is as high as 5 to 10%. So it occurs, the incidence is around 7.6 per 100,000 patient years among patients with IBD. And this risk increases by more than 150 times if these patients have concomitant PSC along with IBD. Hence, surveillance for cholangiocarcinoma is recommended in all patients with IBD and PSC, regardless at which stage they present. And this is more true when in first year after diagnosis. Hence, they should be surveilled. So how do you surveil it? You do an appropriate imaging, either by MRI and MRCP, along with LFT every 6 to 12 months. Now coming to extraintestinal malignancy. It has been seen that inflammatory bowel disease is associated with non-melanoma skin cancers, hematological malignancies, lung cancers, melanoma, multiple myeloma, and non-Hodgkin's lymphoma. Now, whether these hematological malignancies, they occur because of inflammatory bowel disease or because of the treatment being given to them, and it is the drugs which leads to development of hematological malignancies, is not very clear. And as of now, there is no insufficient evidence to implicate either of them. So now, what are the common drugs used which can give rise to malignancies in patients with receiving therapy for IBD? So thiopurine can give rise to lymphoproliferative and myeloproliferative disorder, non-melanomatous skin cancers and cervical cancers. TNF antagonists can give rise to lymphoma and melanoma. When TNF antagonist is used in combination with thiopurine, it can give rise to lymphoma. Vedolizumab and ustekinumab, fortunately, no malignancies have been detected, and therefore we can make use of this when you detect malignancies in patient with IBD. JAK2 inhibitors, they can cause all malignancies but for non-melanomatous skin cancers. And methotrexate is known to give non-melanomatous skin cancers. So let us discuss in brief about important drugs. So thiopurine, there is increased risk for lymphoproliferative and myeloproliferative disorders. The risk is more in elderly patients. Hence, it is important that you screen them for Epstein-Barr virus, especially in young adults before starting therapy. And in patients with negative EBV IgG, you should think of other medications than thiopurines. As far as skin cancer and thiopurine is concerned, there is increased risk for non-melanoma skin cancer, and therefore these patients, before starting the treatment, should undergo a skin cancer screening and use sun protective measures. As far as cervical abnormalities in females is concerned, it is well established fact that they have increased risk of cervical high-grade dysplasias and malignancies. Therefore, women suffering from IBD and who are going to be started on thiopurine, they should undergo a screening program before starting of the therapy. Now we come to a situation where you have a patient of IBD and you on surveillance detect malignancy. So how will you manage? So I'm going to take you through this algorithm. So you have a patient with IBD and you detect a cancer. So there is a presence of, if there is a presence of active cancer, important is that you avoid immunosuppressors and anti-TNF. Then you find out whether you start the cancer therapy will get precedence over the management of IBD, and you see whether this cancer therapy also helps in managing IBD. If the answer is yes, then you continue with the treatment. But if it is not helping IBD, then you can start on steroids. And as I said, that vedolizumab or anti-TNF can be started. However, it's important to note that you should avoid immunosuppressants. Now, if you are not going to be starting an active cancer treatment, that is chemotherapy, and if the IBD is active, then you start on steroids or vedolizumab or anti-TNF. If it is not, you can start 5-ASA, but again, it's important that you avoid immunosuppressants. Now, we come to another situation where you have a patient who presents with IBD and gives history of malignancy in past, colorectal malignancy in past. So how do you manage it? So you find out first whether the malignancy remission is more than 2 years, and if it is yes, and if the patient has active IBD, then if patient has active IBD, depending upon the disease activity, if it is moderate, then you use steroids. If it is not effective, then you can use vedolizumab or anti-TNF or ustekinumab. However, it is important that you avoid thiopurines and immunosuppressants. If the disease activity is mild, then then you can start the patients on steroids or mesalazine. If the malignancy is, if the IBD is active, then you should avoid thiopurines and use mesalazine, steroids, and consult an oncologist for further treatment. However, if the IBD is not active, then you can give mesalazine. If the IBD is not active, then you keep the patient under surveillance. And if there is early detection of flare, you start on steroids. If there is no efficacy with it, then again, as we said, anti-TNF monotherapy or vedolizumab or ustekinumab can be started. So this is as far as the management of patients of IBD with prior history of colorectal malignancy. Now, in the end, I would like to say that as far as malignancy-associated IBD is concerned, the current scenario spells good news for us because the incidence for malignancy in IBD is declining over the years. And this can be attributed to improved controlled inflammation, maintenance therapy utilization, and a good surveillance program, which leads to early surgery in cases of medical resistant diseases. Now I come to the second half of lecture is that malignancy associated with familial adenomatous polyposis. So we all know that FAP is an autosomal dominant polyposis syndrome with varying degrees of penetrance. The primary genetic defect is a germline mutation in adenomatous polyposis coli gene. It has diverse phenotypic expressions like Gardner and Turgot syndrome, and the patient has 100% lifetime risk of developing colorectal carcinoma, especially by the age of 30 to 40 years. And hence, prophylactic colectomy is recommended in all these patients to reduce the risk of developing carcinoma by late 20s or early 30s. Besides this, it's very important to note they also have increased risk of gastric and duodenal adenocarcinoma, hepatoblastoma, and desmoid tumors. So as far as colonic manifestations of malignancy in these patients is concerned, they will present with diarrhea, abdominal discomfort, bleeding PR, and you would naturally do a colonoscopy, and you will be finding numerous colonoscopy, more than thousands, what they describe as a carpet of polyps. It's important to remember that you have an entity called as attenuated FAP, where there are reduced number of polyps, less than 100, around 30 polyps. This usually occurs at the later age, around 50 years, and it predominantly affects the right colon. So as far as the definitive management of FAP is concerned, the treatment of the only definitive treatment is surgery, which includes total proctocolectomy with ileal pouch anal anastomosis. Having said that, there is a role for total colectomy with ileorectal anastomosis in certain select subgroup of patients. So who are this? Female patients who have yet to complete their reproductive life, patients who are young, who are to get married. So you ask them to get complete their this. And most important rider for doing ileorectal anastomosis is that they have to be motivated enough to be under constant surveillance, because in the remnant rectum, the distal rectum, there are high chances of malignancy which can occur, and you may have to do a completion total proctocolectomy in these patients at a later date. Now we come to extracolonic manifestations, and the most commonest extracolonic manifestation is congenital hypertrophy of retinal epithelium. It is asymptomatic and it is seen as a flat, localized, pigmented retinal lesions. Then you have patients who present with Gardner syndromes like osteoma of the mandible or skull, dental abnormalities such as impacted teeth, supernumerary teeth, odontomas, and cysts, which are usually identified on X-rays. You have desmoid tumors, and this can occur in as high as 10 to 15% patients of FAP. These are solid connective tissue tumors which are benign, but they have capacity of significant growth and local invasion. There is increased incidence in abdominal cavity, and patients who have family history of desmoid tumors, the risk increases by 25%. Females are more likely to develop this, and surgical trauma is usually associated with increased incidence. So they are large, firm, painless mass. They are oval or round with irregular margins. And as per NCCN guidelines, these group of patients require annual clinical examination in form of abdominal palpations and imaging, especially in patients who have history of FAP and desmoid tumors. MRI is supposed to be best imaging modality because it can help you to assess the relationship with surrounding structures and also determine local invasion. You can treat them medically with anti-estrogens, prostaglandin inhibitors, tyrosine kinase inhibitors. Local therapies like cryotherapy and radiation have also been advocated. However, the definitive treatment remains surgical excision with negative margins. Now coming to gastric polyps, 90% of patients with FAP, they have gastric polyps. Majority are fundy gland polyps. They do not develop into cancer. However, non-fundy gland polyps, they progress into malignancy and they can be managed endoscopically. High-grade dysplasia in any of the gastric polyp warrants endoscopic or surgical resection depending upon its size and site. As per the NCCN guidelines, In these group of patients, upper GI endoscopy should be done regularly, beginning from 20 to 25 years of age. If feasible, they can be treated endoscopically. However, patients with high-grade dysplasia and malignant degeneration, they warrant surgical resection. Now, periampullary and duodenal carcinoma, they are also very common. It arises amidst the duodenal polyps, and it is one of the leading causes of death in FAP after colonic cancer. The lifetime risk of these patients developing duodenal carcinoma is approximately 5%, which occurs by the age of 60. Their median age of presentation is around 50 to 55. It primarily affects the second and third part of duodenum, and hence these patients' surveillance should start at the age of 20 to 25 years, and endoscopy should be repeated every 2 to 3 years. Polyps with dysplasia should undergo an endoscopic resection. However, endoscopically unresectable polyp or polyp showing features of invasive malignancy, surgery is recommended. And finally, hepatoblastoma. They have increased incidence, though not as high as the other conditions we mentioned. It predominantly occurs in male children less than 5 years of age. As of now, there are no universally endorsed screening recommendations, though in patients with high risk, you can do a periodic liver USG and AFP levels every 3 to 6 months. As far as thyroid cancer is concerned, it occurs in 2% of patients with FAP. And the most common thyroid malignancy to occur in these patients is papillary type of malignancy. It is high occurrence amongst women, so much that almost 90% of thyroid cancers are in women with FAP. So all the females who develop, it is important that other way, you should rule out FAP also. And hence, in these patients, annual USG screening should be started early in teenage years. Finally, to summarize, as far as management of FAP for malignancy is concerned, there should be a regular screening and surveillance for polyps. For colon, prophylactic colectomy with or without proctectomy should be done to prevent CRC. It's important to monitor for extracolonic manifestations. And in this group of patients, genetic counseling for family members is extremely important. And all these patients' relatives, first degree relatives, should be surveilled for FAP and its manifestations. Thank you very much.
Thank you, Dr. Chetan. Before I hand over to Ram and Deeksha for final 5 minutes, I can see Dr. Deep Goyal. He's also one of the senior surgeons with interest in colorectal surgery. Deep, would you like to make any quick comments or give any specific take-home messages before Deeksha and Ram close?
No, thank you, sir. I think it's an excellent presentation by Dr. Chetan as usual. I think he has summarized it very well. I think the challenge lies in cases where, patient is suffering from active colitis and develops a low rectal cancer. Then the picture gets very confused from the treatment point of view. And I think that is something which we should bring out during our discussion.
So Deeksha and Ram, any take-home messages, especially for the students?
I have a small question for Dr. Chetan. So,
yeah.
Sir, in the patient with remission, in a ulcerative colitis patient with remission, now you have a left colon cancer. So what will your take for management of this patient? Whether segmental colectomy or still you will like to go for ileal pouch anastomosis?
So basically, if the patient has a dysplasia and he has a left-sided colonic malignancy, so it depends upon if it is above the involving the rectum or it is above the rectum. So if it is above the rectum, I can safely do a total colectomy with ileal pouch and anastomosis. I will not do a segmental colectomy in these patients. However, if it is involving the middle or distal rectum, then I will do what they call it is you do a mucosectomy and hand sew and anastomosis in these patients. I will not do a stapled ileal pouch in anastomosis.
Deeksha, any closing remarks?
So thank you. So that was a very comprehensive and a very well-framed talk. I think we'll take the last question, which is there on the YouTube chat box by Dr. Darshan Patel, and I think
Yes.
we will close it at that. So he asks if there are any predictors of a difficult TME. So I think it makes a lot of difference to understand how a TME is done, the body habitus of the patient, the physiology of the patient, how bulky the tumor is, whether preoperative radiation has been given or not. All of these factors will constitute how was the primary tumor before even giving neoadjuvant therapy. Was it involving the CRM? Were there bulky nodes around it? Has there been a previous pelvic surgery? All of these things make a difference. Also, the definition of a difficult CME will change with time. Sometimes it is difficult to do a CME in a male patient who is either obese or who is very tall, because the pelvic anatomy is very acute and it is difficult to go down into the pelvis, especially if it's a lower rectal tumor or a mid rectal tumor. I think with time, all of us learn in our surgical experience to kind of overcome those problems. We learn the nuances of navigating the anatomy from here or there. But I think these are the things that one must keep in mind. An obese patient, a tall male patient with a very narrow pelvis, mid and low rectal tumor, bulky tumors to begin with large lymph nodal masses, and pre-operative radiation.
Also, if I may add, sometimes, Deeksha, in these patients who was already, have inflammatory bowel disease for a long time, their mesentery and mesocolon can get shrunken. So it's difficult sometimes to get the colon down to the pelvis. So that also should be kept in mind. You might end up, doing an APR in these patients.
Absolutely. Yes, sir.
And a post-hysterectomy female.
Yes, that's very true.
Okay, so I think I have the pleasant duty to thank Ram and Deeksha for agreeing to moderate, and to Sharvari, Chetan, and Sanyukta for presenting. Thank you, Dr. Deep, for joining. Thank you very much. We will
definitely
hope to see you in one of the future master classes on a topic of your interest. Sure. There are a few other senior colleagues who have joined. I would like to thank them. I saw Dr. Banerjee was there, and earlier Dr. Nabeen Podyal had joined from Nepal. And on YouTube, at the moment, we had maximum 35 people watching. But what we have observed that these videos which are uploaded on YouTube by Dr. Avinash Rang's team, they have large number of views. I just saw that the last month masterclass, which was on pancreatoduodenectomy, has already had 350 plus and 400 plus views. And some of the masterclasses are almost touching 1,000 views. So I thank all the colleagues who have contributed to all the masterclasses. Students, please do join Jaipur Surgical Tutorial. I have already projected Dr. Anand Naga's WhatsApp number. And please email me if you want to read more about CA rectum. I'll be happy to share the chapters on CA rectum from my books on clinical as well as operative surgery. So with that, at 8:59, I will take everybody's permission to close this masterclass. Thank you, everyone. Have a good night.
Thank you.
Thank you, sir. Thank you, sir.
Good night, everybody.
Good night.
Bye.